All right. My presentation is on cellulitis in the community, going over the assessment, management, and the differentials. What is cellulitis? Cellulitis is described as a bacterial infection involving the dermis and subcutaneous tissue. You can see the diagram that shows the layers of skin there. Uh, Affects the dermis, subcutaneous, all the way down to the subcutaneous. It's often associated with lower limb infections, but it can be anywhere. It can pop up anywhere you have skin. According to BPAC, two-thirds of cellulitis cases are caused by Streptococcus pyogenes and other Streptococcus strains. Most of the remaining cases are caused by Staphylococcus aureus. These bacteria will usually begin with a breach in the protective dermis layer of the skin. The breach can be obvious, such as a surgical wound or laceration, but it might be difficult to detect if it's from something small like an insect bite or cracks in dry skin. The extended care paramedic can treat simple cellulitis in the community. You need to take careful history taking and thoroughly assess the patients. ECPs can manage mild to moderate cases in the community and can initiate treatment on severe cases while activating other treatment options such as transport. ECPs can also serve as an alarm bell, identifying more concerning features of infection that will require advanced care. The presentation is going to be in this basic context. It's going to be a clinical presentation and assessment. We're going to move on to differentials and complex mimics, management strategies, clinical reasoning and decision making, and priority populations in New Zealand. Clinical features common in cellulitis are pain, swelling, erythema, heat, fever, malaise, edema, blisters, ulcers, and lymphangitis. Systemic signs let you know that the infection has spread beyond the local area of redness. It's increased heart rate, tachypnea, systolic blood pressure of 91 to 100, decreased temperature, altered mental status, and deterioration of their functional ability. Pretty much your sepsis guidelines. Key components of the assessment by ECPs is history taking, a physical examination, and assessment of red flags, and going over your differential diagnoses. Your history taking, items of concern, things that affect the immune system, such as steroid use, cancer, like if they've been undergoing chemotherapy, or events that could have introduced the bacteria, such as trauma, surgeries, tattoos, etc. In our physical exam, we always do look, feel, move. You're looking for redness. The redness, it's good to note if there's definition in the borders, if it's kind of undifferentiated versus sharp lines. Swelling, the skin can be taut, have an orange peel appearance. Looking for those scratches, those openings that could have introduced the bacteria. Lymphangitis is an indication that the infection is moving up the lymph system. That can be obvious in the tracking signs if you see red lines going up from the wound towards the nearest lymph nodes. So look for swelling in those lymph nodes. For demarcation, you can draw lines around the edges of the wound, just so you can go back later and see if it has spread. If somebody else has already assessed them in the past, you can compare it to their drawing. You can feel the skin for warmth, tenderness, fluctuance. Fluctuance is the feeling of fluid under the skin, like abscesses and boils. And then you can feel for crepitus, which is like a popping feeling. If there's certain types of bacteria, it creates gas under the skin that gets into the cutaneous tissue. You can let the patients see how they move the limb. There might be pain on movement. There could be, they don't want to move because of malaise that comes along with the infection. You can assess for circulation, motor function, and sensation distal to the injuries, and observe for movement and full range of motion in the joints. Red flags, these are red flags from our CPGs and from the Health Pathways 3D. Severe pain, sepsis features, cellulitis as a result of a diabetic foot ulcer, orbital cellulitis, suspected necrotizing fasciitis, temperature over 40 degrees, sepsis with any features indicating antibiotics, cellulitis over a joint. Some diagnostic tools we have in the field. You can swab for cultures. We don't normally do this, but if there's discharge, you might want to swab it if you suspect MRSA or if previous antibiotic administration hasn't improved the infection. Once again, you can demark the outside of edges of the wound just for future reference. And if you look at this table here, it has features of sepsis in the three categories, mild, moderate, and severe. So you can go over this tool that's in your CPGs to address the severity of it. Conditions that mimic or complicate cellulitis are necrotizing fasciitis, MRSA, osteomyelitis, erysipelas, and septic arthritis. Misdiagnosis can delay life-saving interventions, and some of these are very dangerous. We'll start with a very dangerous one, necrotizing fasciitis. Necrotizing fasciitis is an infection that gets below the subcutaneous layer into the fascia, or the connective tissue between the hypodermis and the muscle. Three primary features when you're dealing with these patients are disproportionate pain. It's more painful than you would expect. Rapid spread and rapidly developing sepsis features, dropping blood pressure, tachycardia. It can initially appear as localized erythema, some redness. Damage causes thrombosis and tissue necrosis with severe pain and rapid progression. After 3 to 4 days, it can present as a purple rash. Dark fluid-filled blisters may form, and the tissue dies and may turn dusky to black as necrosis develops. Severe pain continues until necrosis destroys the nerves. Hypotension and high fever develop. Necrotizing fasciitis caused by the bacteria Clostridium profungus and Clostridium septicum can form the gases in the subcutaneous tissue, creating a crepitus or crackling when the skin is palpated. Next one is MRSA, methicillin-resistant Staphylococcus aureus. Compared to a typical case of cellulitis, MRSA is similar in appearance, with a lot higher likelihood of abscesses and blisters being the main difference. Besides the higher likelihood of blisters and abscesses, you can be further suspicious if they've had antibiotics that did not improve the infection. In cases where you suspect MRSA, you can go ahead and swab that one to get a confirmation on the organisms involved. Osteomyelitis is an infection that goes deep and reaches the bone. Diabetic foot ulcers are often the culprit, but any wound over a bone, such as the tibia where the skin is thin, can develop an osteomyelitis. If patients have open trauma, surgical implants, poor circulation, diabetes, chemotherapy, steroid use, hemodialysis, etc., these are all risk factors that can increase the likelihood of forming the bone infection. It can be difficult to diagnose osteomyelitis in the field. You'll get tenderness over the bone. If it's in your lower extremities, it can be difficult to bear weight or impossible to bear weight. If you have chronic wounds, it's more likely, and other risk factors would be your biggest clues towards osteomyelitis. This picture here, by the way, is a picture of osteomyelitis that formed after an IO. Kind of interesting. Erysipelas is an infection that affects the superficial layers of the dermis. It's the superficial as in the highest layer, not as in the infection itself is superficial. As you can see from this picture, it can be quite bad. It can extend down in the cutaneous lymphatic system, but it's primarily that top level. Erysipelas is known by its sharp borders. It has very well-defined edges. Common pathogens are Streptococcus pyogenes, Staphylococcus aureus, Yersinia enterolytica, Streptococcus pneumoniae, Haemophilus influenzae, and Klebsiella pneumoniae. Erysipelas often comes on quick, and it's accompanied by fevers and chills. Septic arthritis is an infection that gets into the joint. Staphylococcus aureus is the most common bacterial cause, but it can also be caused by Neisseria gonorrhea infections. So you'll want to keep this as a differential if you have patients with that STD history. The knee is the most commonly affected joint. Next is the hip. On assessment, it can be difficult to rule out septic arthritis in cases of cellulitis where the infection is located over a joint. It may be that it hasn't fully invaded the joint, but it's on its way. So you're really kind of taking it in your own hands if you release a patient into the community who has cellulitis over a joint. That over a joint might be a reason you might want to transport them. Management in the community. You have oral versus IV antibiotics. In mild cellulitis, we treat with flucloxacillin for 5 days. If they're allergic to that, you can give them cephalexin for 5 days as well. In moderate cellulitis, you increase the dose to 1,000 milligrams of flucloxacillin. Have it 4 times daily. With that allergy to penicillin, you can increase that to 1,000 milligrams. Cephalexin, or 300 milligrams of roxithromycin PO once a day. A PO once a day might be something for a patient that you think might not be up for taking their medication 4 times a day. For severe cellulitis, an immediate referral to the ED might be appropriate. You might want to consider a community IV antibiotic course if a local pathway is available. If the patient's being treated in the community, and you're unable to arrange IV antibiotics, then you can give 1 gram of cefazolin IV and supply oral antibiotics as you would in moderate cellulitis. If you do give IV antibiotics in the field, you need to monitor the patient for at least 20 minutes. You might get that blood pressure drop that sometimes occurs with IV antibiotics. A referral to the ED should be made when there's features of sepsis present, if you're suspecting necrotizing fasciitis, if mobility is altered, if their cellulitis is severe, if there's severe edema, if the patient has had chemotherapy in the last 4 weeks, or the infection is on the hand or in the periorbital area, if the patient's elderly or has significant comorbidities. We have limited diagnostic capabilities in the field, so we have to perform a thorough history and assessment and carefully weigh out our risk factors when we're making our decisions. Just keep in mind, erysipelas affects the most superficial layers of the skin, while cellulitis gets down in the subcutaneous layer. MRSA is similar, but has antibiotic resistance and is likely to come with abscesses. Necrotizing fasciitis affects the fascia between the skin and muscles, and it's incredibly painful. Septic arthritis occurs when an infection invades a joint, often limiting mobility, and osteomyelitis occurs when the infection invades a bone. All right. Priority populations in New Zealand. Diabetic patients are more prone to skin infections because they have lengthy healing times on their wounds. Because Maori and Pacific populations have a higher incidence of diabetes, that puts them in the risk factor for these infections as well. Maori children have been showing higher rates of skin infections when compared to the European kids in New Zealand. And the rates are worse in urban areas. So the North Island in general has higher rates than the South Island. Obese patients have a higher risk of infection because the areas where the skin folds hold moisture, creating an environment for bacterial growth. Smokers have delayed wound healing and higher rates of cellulitis. And traditional tattooing techniques in Pacific populations introduces a greater risk of these infections as well. So, to recap, cellulitis has hot, painful areas of the skin with poorly defined demarcation. Erysipelas has sharply defined borders. Necrotizing fasciitis has gray areas, rapidly spreading, is extremely painful, and rapidly progressing features of sepsis. Necrotizing fasciitis has gray areas, is rapidly spreading. I'm sorry, repeating that. MRSA has antibiotic resistance and frequently forms boils, abscesses. Osteomyelitis can have tenderness over bones, and in lower extremities can cause the inability to bear weight. Septic arthritis presents with painful joints and palpation and reduced range of motion. For management pathways, cellulitis, MRSA, and erysipelas can be treated in the community based off the severity table and recognition of your red flags and risk factors. Osteomyelitis, septic arthritis, and necrotizing fasciitis are true emergencies and should be treated in the hospital setting as quickly as possible. Pacific populations have been shown to be at higher rates of infection, so extra suspicion is warranted in their assessments. Final thoughts. High vigilance and early action can identify catastrophic conditions. Early treatment can spare patients some of the worst outcomes. Some of these infections, especially necrotizing fasciitis, that can be deadly. The septic arthritis can ruin mobility. Osteomyelitis can lead to amputations in the future. It's not patients you would want to leave in the community and have those bad outcomes be because of your advice. We have our references here, here, and that's it. Do we have any questions?
Cool. Thanks, Travis. That was really interesting.
Thank you.
Spoken as someone who's also doing cellulitis assessment, I feel like I still learned stuff, so that was cool. What was the do you have any other sort of information on the use of probenecid acid?
I don't know.
Okay,
I could
no, all
look that
good.
up and get back to you later.
Okay, no, that's all good. I just came across it as like another, I think it sort of supports oral antibiotic use in the
Yeah.
community. I need to look into it myself.
I kind of
I just saw it
summarized some of the
mentioned on your
treatment options
PowerPoint.
on the slide, but it was mentioned, but
Hmm.
I didn't have any deeper information on that.
No, all good.
I kind of found quite interesting. I've always found quite interesting the guidelines in regard to moderate cellulitis treatment with your three different options of medications there, your Fluclox 4 times a day, your Kefalexin 3 times a day, and your roxithromycin 1 times a day. And you even mentioned that, your Roxy 1 time a day might be best for some populations. Did you find anything about whether any of these medications are better than others?
No, as far as I know, you're getting similar results with all the different medications, but yeah, the Roxy might, obviously, you're going to get better results with a medication if they're taking the full course. So that once a day could be quite beneficial.
Yeah, I thought so. I've also found it quite interesting because I wrote down quite early on what would you be looking for if you were suspecting MRSA, but then you answered it. And the abscesses and blisters, I didn't know that, so that was quite interesting to find out.
Yeah, and they're quite painful.
Yeah, I'm sure they are. But yeah, no, otherwise, like really, really good presentation. I learned quite a lot actually.
Oh, great.
It was well set out as well, Trav. Just like your structure for it was really good. So, yeah, good job, buddy.
Thank you.
Yes.
All
Yeah.
right. Stop recording.